small for cardiac surgery. They might feel I need to wait till my child becomes at least 5 kg or 10 kg before he will be fit for the surgery. Now, this might have been true, say, 30 years back, but at present, in the present era, there is no minimum age or weight for surgery. Surgery is done whenever it is indicated, and the timing depends both on the diagnosis and the symptoms of the patient. So suppose you have a child with an interrupted aortic arch, an obstructed TAPVC, a transposition of great arteries with intact septum, a tetralogy of Fallot with pulmonary atresia. These children will need a surgery or a cath lab intervention within the first few days of life, regardless of what their weight is. The smallest baby we have operated at SRCC was 500 grams. That was a PDA ligation. The smallest open heart surgery was around 1.2 kgs. And the smallest cath lab intervention was a 1 kg baby with severe coarctation. Is there a minimum age or weight for a cath lab intervention? In a cath lab intervention, remember we go from the vessels in the groin, the femoral vein or the femoral artery. So our main limiting factor is whether the vessels are big enough for us to put large catheters through those into the heart. So usually for a balloon angioplasty, we can use very small lumen of vessels, and you can do balloon angioplasties in a patient as small as 1 kilogram. For children who need device closures, as I mentioned, the preterm PDA device or the Piccolo device is now approved for children above 800 grams of weight. VSD devices, we generally would like the child to be about 5 to 6 kilograms of weight. And for ASD device closure, we want them to be around 8 kgs of weight or below. So surgical and intervention risks obviously will be higher in small babies, and studies have shown that when babies are less than 2.5 kgs weight, they have an increased risk of infection and of hemodynamic instability. But these babies still do well once they have recovered from their procedure. And if you do not treat them, they will succumb. So there is really no option but to treat them, accepting that slightly higher risk. And remember that if you wait for a threshold of weight such as 5 kg, most critical congenital heart defects are associated with severe failure to thrive. So it is unlikely that your patient will actually achieve that weight of 5 kg before they become very sick. So again, I would like to stress here, timing of surgery depends on the diagnosis and the symptoms of the baby, not on the age or the weight. Cardiac surgery is very high risk in small children, and it is better to not treat a patient than for them to undergo cardiac surgery. This is something we still hear when we go out for camps to rural areas. There is this fear against cardiac surgery, especially if a child has to be subjected to it. And I think it is because of this morbidity associated with opening the chest and accessing the heart. But in the present era, the overall cardiac surgical mortality at good tertiary centers such as ours is less than 3%. And even high-risk surgeries such as an obstructed TAPVC or a neonatal BT shunt, we are at less than 15% neonatal mortality. Remember that for any cardiac procedure, we would always weigh the risks versus the benefits, and surgery or intervention is only going to be offered if we feel that the benefits are significantly more than the risks involved. So yes, cardiac surgery is safe, and whenever it is indicated, it should be done without any hesitation. The next myth we come across is that the parents might feel my child has been diagnosed with a heart disease. He or she will have a very limited quality of life. They will not be able to exert themselves when they grow. They will have severe activity restriction. Female patients might not be able to get married or get pregnant. Again, that is very untrue. Most children with heart disease are completely cured with timely surgery or intervention. They have a near normal life expectancy, normal exercise tolerance. They can have a very good quality of life if treated appropriately. So most patients who undergo curative surgery, they will have normal adulthood. They can have a normal pregnancy, and there is really no activity restriction. Around 20% of CHD will have a major defect where, say, one side of the heart is not formed. And these patients, we cannot offer them a curative treatment. We offer surgeries which are known as palliative procedures. And whenever you do a palliative procedure, you're basically giving palliation to the symptoms, but these hearts cannot be corrected to the normal connections of a two ventricle heart, and these are single ventricle physiologies. So in these 20% of patients, yes, there are limitations in their activity, lifestyle, and their life expectancy. The next myth, if a fetal echo has diagnosed a hole in the heart, some patients might think, should they terminate the pregnancy? And this is unfortunately becoming far too common in the present era as more and more people are doing fetal echoes. So what we have is fetal echoes not just being done by pediatric cardiologists, but also being done by radiologists and perinatologists who are very good at making a diagnosis, but who don't really follow up these patients post-operatively or postnatally. So they aren't able to give a good long-term outcome to the parents. So as you might know, the commonest cardiac defect is a VSD, and so obviously fetal echoes will detect VSDs most commonly. And VSDs have an excellent long-term prognosis when they are treated correctly. A lot of these VSDs might close off spontaneously, and even the large ones which require surgery, the patient is absolutely normal after that. So definitely there is no indication for termination of pregnancy if a VSD is diagnosed on a fetal echo. Only complex cardiac conditions such as a hypoplastic left heart syndrome, tricuspid atresia, or other single ventricle physiology, where the patient after being born would require multiple surgeries with a poor long-term prognosis, those patients, after discussion with cardiac specialists, the parents could consider a medical termination of pregnancy. So I would like to stress here that any patient who has a diagnosis of a congenital heart defect on fetal echo, they should definitely have a consult with a pediatric cardiac specialist before they decide regarding proceeding with the pregnancy or not. Also remember that most babies who are antenatally diagnosed with a CHD can have a normal vaginal delivery. There is no increased risk of a vaginal delivery versus a cesarean section. One of the benefits of fetal echo is that once a important critical congenital heart defect has been diagnosed, the patient can then plan to deliver at a cardiac center such as ours, and then the baby can be assessed immediately after birth, and we can offer them optimal timely treatment. So that has started happening a lot more commonly in the last 4 to 5 years, where because of antenatal diagnosis, the postnatal outcomes improve dramatically. The next myth, and this is mainly for the pediatricians and the general practitioners, is if you refer a patient for an echo and the report comes back as a large VSD with a severe pulmonary hypertension, there is always a question in your mind, do you start these patients on sildenafil? And the answer to that is no. You do not want to start a patient on a pulmonary vasodilator before treating the CHD. And the reason for that is that if you start a pulmonary vasodilator before closing the shunt, that will decrease the pulmonary vascular resistance, it will increase the flow through the defect, and it will worsen the cardiac failure and the pulmonary edema, and therefore it will worsen the clinical condition of the baby. So yes, some of these patients might have pulmonary hypertension, which might require treatment with pulmonary vasodilators, but that is only started after the surgical closure of the defect. So I would like to stress again that any patient with a diagnosed congenital heart defect must have a consultation with a pediatric cardiac specialist to decide the treatment plan. The treatment needs to be tailored to the patient's diagnosis and symptoms, and the prognosis of most congenital heart defects, when treated in a timely manner, is very good. These are some of our patients treated here over the last 8 years. Thank you for your patient hearing. I would be happy to take any questions if anyone wants to ask something. So we can go on to the, sorry, did anyone want to ask?
I think they are muted.
So the next talk is by Dr. Pradeep Kaushik, Head of Pediatric Cardiac Surgery at SRCC. Welcome, Dr. Kaushik.
No. Shall I start?
Yes.
Good afternoon, everyone. It's an opportunity to introduce and share my surgical experience with all of the esteemed guests. And in brief, I'll be taking you all through my experience of pediatric cardiac surgery, just the basic, and what we have done in last 8 years. So I am associated with Narayana Hospital, chain of hospitals for last 18 years. And we started this new unit in 2017 at SRCC Children's Hospital. In last 8 years, we have done close to 6,000 open heart surgeries with excellent outcomes of more than 98% survival. So I'll just take you through how an open heart surgery is done. It's quite exciting and quite intriguing how a heart surgery is being done. So first of all, greetings from SRCC Children's Hospital. It's located at Haji Ali, South Mumbai. And a brief about SRCC Children's Hospital. It's one of the branch of Narayana Health, which has excelled for 2 decades in the field of cardiac surgery. It's a tertiary care center with more than 200 beds. We have separate an ICU, pediatric ICU, and the cardiac ICU. All the super and subspecialty of renal, liver, orthopedic, neuro, all are available 24/7. So what are congenital hearts? Any congenital heart defect is a structural heart abnormality which is present since birth. So it's kind of a manufacturing defect in the heart, are called as the congenital heart defects. The incidence of it is about 1 per 100 live births. So if we extrapolate that incidence, then it comes to about more than 2.5 lakh kids in India are born every year with the congenital heart defects. And the irony is that all over the India, because of the lack of the facility, we are able to treat only 1/4 or 1/5 of the children, and the remaining are left undiagnosed, or even if diagnosed, they are not able to reach to the treatment providing hospital or center because of the lack of funding, infrastructure, or lack of awareness. So the magnitude of problem is huge, and with this understanding, I'll take you through about my topic of how we do an open heart surgery. So before we come on to that, let me just brief you about how the heart circulates. So you see this hand drawn diagram. On the right side is all blue. So all the blood from the body, the deoxygenated blood from the body, returns to the right side of the heart, which is the right atrium, by two big vessels, which are superior vena cava and inferior vena cava. And then that blood goes to right ventricle, and from there it is pumped into both the lungs. They oxygenate. Now you see that lower arrow, it is going and bringing the blood back to the left heart, and from the left heart it is distributed. The oxygenated blood on the left side of the heart distributes the whole oxygenated blood to the whole body. So this is the normal heart circulation, how heart and lungs function. Now the heart actually is not like what I have shown you here. It is like this, how the heart looks like. So this is open chest, and it's not the 4-chamber diagram what I had shown you, but this is just for your reference. So coming back to this diagram, what I'm saying is, suppose there's a defect in this heart in which there's a hole. Now the hole is between the left ventricle and the right ventricle. Let's say there's a VSD. To close that, I have to open the heart. But if I open the heart, all the blood will spill out. So we cannot open the heart unless all the blood is diverted away from the heart. Now the whole body, the baby is anesthetized, but the whole body circulation is maintained by the heart. So we cannot just divert the blood away from the heart. I give you one simple example. Like, let's say one river is flowing and there is a rent in the river bed. You cannot repair the rent in the river bed unless the water is diverted to somewhere else. You make the flow dry, repair it, and then let the river flow again. So it's kind of similar. The principle is same. So what we do is whatever the blood is coming into the heart is diverted through the tubings into the heart lung machine, and then the heart becomes empty. Then we give another injection to make it quiet. So it becomes empty, quiet heart without any blood. And the circulation part of it, the function of circulation to the whole body, is taken over by the heart lung machine. So in next few slides about the heart lung machine, which is the basic of any cardiac surgery, any open heart surgery, and one has to be thorough about it. But for you, it's just a brief, this is just repetition. So that's how the heart lung machine looks. It's a big machine with pumps, tubings, connectors, reservoirs. So it functions three ways. It pumps the blood, which is a heart function. It oxygenates, which is the lung function, and it maintains the body temperature. Whatever body temperature we want, it maintains that. So it's a simple diagram which is showing all the blood from the heart is taken into the reservoir. And do you have a pointer, Mama? No, it's not working. Maybe. Yeah. It's working? Yeah. So all the blood is diverted into this reservoir from the heart, and there's a heat exchanger which maintains the temperature as per the requirement. It oxygenates, and then through this roller pump, after the filter, which takes away all the debris or the air bubble, is given back to the body. So the heart function is taken by this. And to explain to you in a video,
Cardiopulmonary bypass surgery. Venous blood is drained from right atrium or SVC and IVC separately into the venous reservoir by gravity siphon. From the reservoir, the blood is pumped into the oxygenator by the systemic blood pump. The temperature of the blood can be increased or decreased with the help of heat exchanger, which is an integral part of the membrane oxygenator. With the help of gas blender, oxygen and air can be mixed to control the partial pressure of oxygen in the blood. The gas flow, that is sweep rate, can be adjusted independently to remove carbon dioxide. Then the oxygenated blood is pumped into the ascending aorta through the aortic cannula. Sometimes arterial filter is connected in the circuit. A part of the oxygenated blood is diverted to prepare cardioplegia. After cross-clamping the aorta, the cardioplegia pump is run to deliver the cardioplegia to the aortic root through the cardioplegia delivery system, which contains a small heat exchanger, bubble trap, and temperature monitoring port. The blood from the vent cannula is returned to the venous reservoir and also the cardiotomy sucker blood returned to venous reservoir for debubbling and filtration.
so this is the video of one of our cardiac surgery, how we have done it. I'm not moving in this arrow, the laser point. Yeah. So this will be a 15 minutes video of how a patient is. So this is a baby of 1.5 years coming in the pre-operative area. It is painless inhalational anesthesia which we are giving, and the baby takes about 5 to 10 breaths, and there won't be any pain. We have ECG and saturation monitoring, and slowly you'll see that patient will be lined up for all the future monitoring. This is a peripheral line we are inserting. It's all done in aseptic precaution. Majority of the heart surgeries or all the heart surgeries are done with mechanical ventilation, which is by intubating and which can be nasal or oral. So you can see that the baby does not feel any pain even while inserting the peripheral IV line. This preparation of inserting and getting the patient lined up, intubation, takes about 20 to 30 minutes of time. The heart surgery procedure takes about 3 to 8 hours. It depends. This is the painting the area for the neck and the groin. So this is neckline insertion. We insert through the internal jugular vein to have the venous access. And this is usually a triple lumen line which has multi-ports, and we can connect inotropes, the vasodilators, or we can give any drug through that. We can resuscitate if the heart has crashed or there's fall in BP through these lines. These are the transducer used for putting lines. This is one of the radial artery line. This particular baby required radial and femoral artery because of the large PDA, which was like kind of behaving like aortopulmonary window. Otherwise, the transducers are used for smaller babies. We are not able to feel the pulses. And these are excellent newer technologies by which we can put percutaneous lines by Seldinger technique. So the probe is kept on the vessel, and you can see it in the machine, the artery and the veins. You'll just see that. It is important in the smaller weight, and when the lines are used previously for previous surgery, or the patient has undergone cath, or the patient's in shock, it's very difficult to feel the pulses. So this is a very good modality to put the lines. It's a teamwork, and we have dedicated cardiac anesthetists who are lining up the patient with simultaneous monitoring. So we usually insert one central neckline, which is for giving the drugs and volume. There is one arterial line, invasive arterial line, which will give us continuous blood pressure monitoring during and after the surgery. There is the oxygen saturation probe, mechanical ventilation, urinary catheter. All this preparation is required. Upper and lower body temperature. That all comes as the part of the monitoring before we embark onto making any incision. So once the patient is ready, we'll be inserting echo probe. Now you can see the monitor with the heart rate, saturation, arterial blood pressure, and temperature. This is the heart-lung machine getting ready with all the infusions. And the anesthetist is putting the transesophageal probe under anesthesia. And the patient is getting painted and draped for the incision. All sterile, disposable. Control. Now, after skin incision, the sternum is getting cut by the saw. It's a battery saw which opens the sternum. So the incision is made here, and now they are placing the retractor, which will keep the space open. You can see that pulsatile structure, still it's been hidden under the pericardium. And we are just clearing the space. This is the thymic tissue, which will be removed. At this point in time, we are doing the echo also, and we give heparin injection to make the blood thinner. because as soon as we have to divert the blood into the tubings, the blood tends to coagulate. And for it to not to coagulate, we have to heparinize the whole body. Now you can see the pericardium is open and the heart is beating. So let me just show you. So this is from the anesthesia head-end view, and this is right atrium. The whole thing, what you're seeing is the right ventricle, which gives rise to this pulmonary artery. And this is the aorta, which is coming from behind from the left ventricle. This is all what you can see. This is how the heart lies. And on the lateral side, this and this are the lung, which is coming as the video opens. So now we'll be doing some preparation for putting the patient on heart-lung machine, as I had shown in the previous video, to empty the heart and to stop beating. So you'll witness all that in the next couple of minutes. This is the ACT, the anticoagulation time, activated coagulation time. The white light is blinding, so, but you'll see in between that we are cannulating the aorta. We have to put 3 cannula in the heart. One is the aortic, which will return back all the oxygenated blood, and 2 venous cannula, which will take away all the blood to empty the heart into the heart-lung machine. So you see that ascending aorta, which is a high pressure vessel, and we have to cannulate, and these 2 sutures are like kind of purse strings. They keep on the cannula in place. And now we connect it to the circuit of the heart-lung machine. There should not be any air bubble or debris in these tubings. We have to make sure about that. And now this is cannula in the superior vena cava. Not a single drop of blood, whatever you are seeing during the cannulation, goes waste. All gets sucked up into the machine, heart-lung machine, and after filtering, it comes back to the heart and body. So we do not waste, but all the heart surgeries do require blood transfusion. And the patient is right now on cardiopulmonary bypass. You can witness that the heart is now empty, but still beating. So this is the one part of the procedure that the patient has been put on cardiopulmonary bypass. Yeah, so this is empty beating heart. It's still beating. But if I make an incision, there won't be any blood inside the heart. But if the heart is beating, still we cannot suture. And it might suck in air. So we have to make it stop. Now, I'll just show you the anatomy here. What was it? So this is, one second. Sorry about that. So this is a large window ductus, and we have to give the cardioplegia, which will stop the heart. This is the arch and the arch vessels. What you're seeing is snared part. This is the whole ascending aorta and the arch vessels coming out. This turns down into descending aorta, and that's the window. That's the communication between the aorta and the pulmonary artery, and it's huge. That's why it's called as window ductus. So we have to take control of blood flow from all sides, and that's why all this preparation and the threads you can see around. Now I have put a cross clamp here. and we give some medication, high potassium solution, which is called as the cardioplegia, into the coronaries, which will stop the heart. So just witness this. Now the heart is getting slowed. It's a controlled stoppage of the heart. One cardioplegia dose works for about 40 minutes till our surgical part is over. So now you can see the heart has stopped completely and ECG becomes flatline. So this is how it becomes. And now we open the cardiac chambers. So the heart is white and bloodless. Whatever this blood is coming again, it goes back into the circulation and comes back. So it's not going into the waste. I'll just make it a little fast. So there's a patch made of polyester, which we are stitching onto that big hole of ductus. Is done by a very small fine thread, which is of the diameter of our hair. And we have to use magnification lenses to see those threads, but they are very strong and they are non-absorbable. They remain their whole life. Neither this patch is absorbable, it remains there. When the heart will be beating, then also it will remain fixed there. Nothing happens with the size of the patch. As the baby grows, as the heart grows, the hole won't grow, and that's why the patch of the size won't be small. This is a very common question you might encounter once the baby undergoes heart surgery, that what happens when the baby grows. So now the heart surgery is done and cardiac chambers are closed. We have just done the de-airing, whatever the air was inside the heart. And now you'll see the heart slowly starts beating again. But he's low. He's trying to connect. ये charger है. ये क्यों? Oh, it's shutting down.
We are just reconnecting. The Zoom had gotten disconnected. Give us a minute.
Okay, we are presentation. Sorry about the connection loss. We are coming to this. Heart started beating again. And you'll see that ECG also starts gaining it from flat line to some rhythm. Still not the best. And this is how looks better contracting heart. So once it looks it's ready to take the load, we take out one of the venous cannula and give that much blood for the heart to pump, so that slowly we can wean and take and give all the load back to the heart. Once we see that, so you see that heartbeat and ECG looks better, the pressures are coming up to 40, 45. And slowly we are in the process of weaning the cardiopulmonary bypass, and we are seeing the echo of the repair, how's the ventricular contractility. Once we are happy with the repair, we are off the heart lung machine, and this is the final picture. So we take out all the cannula, heart is beating on its own and maintaining the pressure. So the cannula is coming out. And this is post repair. So all the bleeding points, all the suture lines are checked. And the baby is now wheeled out of the OT with all the monitor and chest tube. This is into the ICU. And in a couple of hours, once hemodynamically stable, is taken out from the ventilator and is on spontaneous breathing. So the patient is awake and breathing on its own. And obviously, this is not one man's job. This is a team of about 15-20 people doing this excellent job. There are a few interesting cases I'll just quickly run through. There was a 10-year-old boy diagnosed with tetralogy of Fallot. And when we open the chest, we find usually tetralogies have bigger aorta, but in this we found that the aorta was almost impending to rupture. As you have seen in my 15 minutes video, how the aorta looks like. See this aorta. We could literally see the blood through this. So the plan changed. We had to do the tetralogy repair and we replaced the whole of the ascending aorta, which is called as the Bentall surgery. It is usually done by the adult settings, adult cardiac surgery team, because we encounter these problems in adult cardiac patients. And this is the patient's VSD being closed. This patch is the VSD patch. This is the coronary artery. You can see the coronary being separated. We took out the previous aorta, and these are the sutures by which we have implanted a separate tube which has artificial or the mechanical valve. This is the artificial tube which will function as the aorta, and the black thing what you're seeing is the aortic valve. It's a mechanical valve. Lifelong, patient has to be on anticoagulation because of that. So this is called as intracardiac repair along with Bentall, which is quite rare to do it in one setting. Tetralogy patients do require aortic replacement, but many years later. And this is the final picture of the artificial aorta as the tube and the coronary implanted on that. So this was a unique case. Other than that, this is the same boy at the time of discharge. This is what Supratim had mentioned, that we did a 500 grammer. We've done more than one patients of 500 gram reterms who have failed to wean from the ventilator. The baby is totally of the size of the palm of Vaibhav. Other than that, we have done open heart surgeries. We have done 1.6 kg arterial switch. We have done 1.2 arch repair and 1.4 of a TA PVC. And these are the cases. We have done minimally invasive. There's not much minimally invasive work being done in congenital heart, but we can do for ASD or sinus venosus ASDs. And this is the incision. Normally the incision goes right up to the manubrium sterni, but this baby we have done it by partial lower sternotomy. Or sometimes if they don't want, we do from the right pericardium so that the scar is not seen in the front. So this was the proposed line of incision, but we could manage by half of it. And it's not seen above when the patient wears the shirt or the t-shirt. So far, what we do cardiac surgery scoring is by risk-adjusted congenital heart score. So this is to show that majority of, as the score goes high, 1, 2, 3, 4, the complexity increases. Our majority of the work is about 2 to 3 grade of complexity. Age, we do about 1 month to 1 year is comprising of our majority of the cases. So all our neonates and infants, which is about 70% of our cases. And if you see this, less than 5 kilos or up to 10 kilos is about 73% of our patients. So this is what is our experience of 8 years. The name of procedures, we have done all of it. Atrial septal defect, ventricular septal defects, tetralogies, canal, arterial switch, double switch, L-kappa. All the names in the congenital heart surgeries, we have done it. Along with that, we have been part of the oncosurgery. The team comes from Tata Hospital. The cases which have extension of the tumor in the form of like a Wilms tumor being extended to the heart, or any other anterior posterior mediastinal tumors encroaching on the heart of the bronchus, and they need cardiac surgery as a collaboration. So then we do that also. Otherwise, our strategies are that we use less inotropes. We do fast tracking if the patients are stable. We use handmade conduit. This is a picture of a handmade conduit, which is usually required for pulmonary atrasias or truncus. The normal commercial conduits are available in 2.5 lakhs, and this is what handmade conduit. It's quite cheaper and long lasting. Our ICU stays about 1 to 4 days, and we have been fortunate enough to provide about 98% survival rate for last 8 years, and we have maintained, which is quite comparable to the Western world countries with all spectrum of complexity of our cases. Now, a word of caution just for you to remember, because you might be encountering pre and post-op pediatric patients, which was mentioned in Supratim's talk also, that the patients who are palliative, if you go to the rightmost corner, the palliative surgeries, which are not corrective, patients do require long-term follow-up, and they will be on medications, which are usually blood thinners like aspirin or anticoagulation. We come to the corrective surgeries. If somebody has undergone ASD, VSD, or tetralogy with valve sparing, then they can have normal lifespan without any medications. The complex repair of arterial switch, stenting, valve repairs, they do need long-term follow-ups. And about 10 to 15% of these patients might require some form of intervention, surgical or cath interventions. So to conclude, transposition with intake septum and duct dependent are surgical emergencies. In duct dependent, we should not be providing oxygen, rather we should be giving Prostin. The pre-tricuspid shunts, which are ASD and sinus venosus, are treated at 3 to 5 years of age. The post-tricuspid, the higher pressure shunts, which are the VSD, AV canals, and PDAs, should be closed by 3 to 6 months. Otherwise, they develop pulmonary hypertension. So to conclude, early identification of congenital heart should be done, and curative treatment is possible in more than 80%. That is one-time surgery. The remaining might require 1 or 2 stage surgeries, but if they present late, then irreversible complication develops, or the surgical outcome is not the same. And needless to say that the prognosis of surgical management is good. That's why they should be referred to tertiary center as soon as possible. This is the view of our hospital from Arabian Sea at Haji Ali. Thank you very much. Any other questions you have, or we take it in the last?
We can take it.
All right.
The questions are doubts.
So I'll hand over to Dr. Priya, pediatric cardiologist, to give the talk.
Thanks. Zoom call. This one. Good afternoon. After the wonderful talk about the cardiac surgery, it is really always very fascinating for me as well. even now to see a surgeon operating in this tiny hearts. So I'm Dr. Priya Pradhan. I'm a senior consultant pediatric cardiologist. I'm working in SRCC Children's Hospital since the last 7 years. And along with the cardiac team, we perform all range of pediatric cardiac interventions. So today the topic is basically how to diagnose cardiac diseases, how to look for clues in children when they present to you in the OPDs. So a lot of patients in the outpatient departments, the cardiac diseases are missed because we do not have high index of suspicion. So most commonly we diagnose cardiac disease due to different kind of cardiac symptoms. So like murmurs, if there's a cardiac murmur, if there is cyanosis, the patient has repeated infections, failure to thrive, etc. So this must be the experience of most of us. When I was practicing general pediatrics for 3 years before joining cardiology, these were the things which I used to think of a cardiac disease when I would see this in the children coming to the OPD. But before we go to why we need to diagnose, of course, Dr. Pradeep in his talk has spoken about it, how early diagnosis actually matters. I would like to emphasize on the same thing that it decreases mortality. So if you see, 1 in 4 children will not see their first birthday if those children have serious critical congenital heart disease and have not been operated. So those children, the 2.5 lakh children, which Dr. Pradeep said are born per year in India, 1/4 of them would die by the first birthday if not diagnosed and managed appropriately. Second point to emphasize is timely management. As Dr. Pradeep said, that you have to diagnose them on time to prevent the damage to the heart, to the other organs. And of course, sometimes patients become inoperable if we don't diagnose them on time. And biventricular repair. So sometimes what happens is when the child, so these are like various papers where you can see that how late diagnosis has caused problems to children. Big studies have shown that timely diagnosis and appropriate management has actually changed life of these children. So as we know, it's the commonest birth defect. So if you see, 30% of all the congenital anomalies are cardiac anomalies, and the death rate is much more than. So we see a childhood cancer is rising, but cardiac disease is much more than all the other diseases put together as well. So we have seen that the incidence, how it is about 0.1 in 1,000 childbirths, and that comes down to 2.5 lakh children being born with congenital heart disease each year in India, and 2.4 million people living in India, just because all of them don't get treated. So every year the number get increased, and only the number is taken in control because of the deaths of these children who are not treated. So we have a big chunk of patients who are there out there in the society with congenital heart disease who are waiting for you guys to diagnose them and then refer them at appropriate time. So we just start about how we can see these clues in children right from birth. So I wanted it to be interactive, but it is going to be difficult like this. So what is happening here? Any clues? So if you can see, there are 2 monitors. So one monitor is on the left side, one monitor is on the right side. So we are checking the saturations of this child, both in the upper limb and lower limb. So why are we doing that? So these are certain things that we need to do in a child, in a neonate, to pick up a congenital heart disease right at birth. So I have this fantastic 4 formula, which all of us can use, and we can actually pick up most of the cardiac problems right at birth. So what is this formula? First is look at the 4 limb saturations. And I will give you the examples of each of them. So what if the 4 limb saturation is not the same? All that scenarios, we are going to go step by step. Then look at the upper limb, lower limb blood pressures. So every child who is born in the NSU, if we do these 2 things, many of the heart problems will get diagnosed. Third is, if any doubt, get an ECG done. And the fourth is an X-ray chest. So, and how to catch them the earliest. So this is what we're doing at birth. But as Dr. Sen said, that fetal echo, if you want to diagnose a child with a congenital heart disease even before they are born, then fetal echo is our tool. Because in this case, what happens is when the anomaly scan is done at 18 weeks or 20 weeks, if there is a suspicion of a heart problem, then the child's been sent. I think somebody. Yeah. Somebody, yeah, okay. So if we get a fetal echocardiogram done, so this is done by cardiologists, like pediatric cardiologists as us. And then in this, what we can do is we can diagnose the critical heart diseases. And then we can also tell you about the prognosis of the child. So certain heart problems have bad prognosis. Termination can be given as an option. And then secondly, if there are certain heart problems which need to be for the baby to be delivered at a cardiac center, because certain drugs need to be started, like prostaglandin needs to be started immediately after birth, or we need to do certain procedures immediately after birth, like a balloon septostomy in a patient with a detransposition of great arteries. So there are so many things that we can plan. The family can be mentally as well as financially prepared to receive such a child. So fetal echo is a great tool, and that really helps in diagnosis. Again, for that, high index of suspicion has to be raised by the sonographer or the doctor who is doing the fetal scan or the anomaly scan. So let's go to the scenarios that I was talking about. This is a child where we saw that there were the saturations in the right upper limb is low, it's less than 90, left lower limb. So why we do right upper limb and left lower limb is also what I'm going to tell you about it. It is because the branching of the aorta. So the aorta, usually everybody, most of us have a left aortic arch. So in the left aortic arch, what happens is the right upper limb is supplied by a vessel which is preductal, that is the PDA. PDA is a vessel which connects the aorta to the pulmonary artery. So this is present in all the fetuses. But once they are born, this PDA closes. But until and unless the communication is present, the oxygenated blood and deoxygenated blood are going to get mixed. And that's why the saturations of these two limbs are representative of the preductal and postductal saturations. So that is why we always see four limb saturations, or basically see at least two limbs, right upper and left lower. Sometimes if the arch is is not left sided and it's right sided, it's always best to see the four limb saturations. So now this child has low saturations in both the upper limb and lower limb, and then we give oxygen and there's no improvement in the saturation. So again, this is third line is also very important, because this itself is a test which is called as hyperoxia test. In this test, what we can do is, in congenital heart disease child, when there is a shunting lesion, despite of giving as much oxygen, there's a mixing happening in the heart, and that's why the saturations will never improve. As opposed to a child with the respiratory problem. In these respiratory problems, when you give high FiO2 or if you give P, the saturations will improve. So here in this case, we are seeing already that the saturation is not improving. So what are the possible diagnoses? I have given you a clue that this most possibly is a congenital heart disease. Now, we have seen this child as a neonate. So which conditions can present with cyanosis in a newborn? So as we spoke, it's all about mixing lesions, something like a TAPVC. So what is happening in a TAPVC? So usually the pulmonary veins have to come and drain into the left atrium with all the oxygenated blood. But instead of that, they are coming and draining into the right atrium. So there is complete mixing of deoxygenated and oxygenated blood in the right atrium. So the saturation, which was 99% to 100% in the left atrium, is now mixing with the saturation of 70% of the systemic veins. And that's why the baby always will have desaturation in such conditions. Another condition where there is total mixing is the truncus arteriosus. So what is the truncus? In which the pulmonary artery and aorta are not separate, but they're arising as a single trunk from the heart. And that's why this obligatory complete mixing, that is the left ventricle and right ventricular blood together, is pumped into the truncus. And those patients always will have low saturations. The next condition which we talked about was the DTGA. What is a DTGA? Is detransposition of great arteries. This is again present at birth. Why? Because instead of the aorta coming out from the left ventricle, we have the pulmonary artery coming out from the left ventricle and the aorta from the right ventricle. So the great arteries have been transposed. The only way the baby can survive here is by mixing the blood in some way. So there are certain mixing points like the atrial septal defect. So the PFO is a defect which is present in all fetuses for the maternal blood to reach the baby's body. So that remains open and the PDA remains open, and only then the baby can survive. When these two lesions start closing, the baby will present. So any baby which is presenting with low saturation, which is not improving with oxygen, always think of a cyanotic heart disease. What if the saturations are improving? Then we can, of course, think about lung disease or primary pulmonary hypertension in the case of newborn fluid. Second scenario, as we spoke about the preductal and postductal, the right upper limb saturations are more than 95, but the right lower limb saturations are less than 90. So we have desaturation in the lower limb. So what would be the possible diagnosis? So as we spoke, this is about a duct-dependent circulation. So what is happening here is the upper limb is getting the blood from the heart, which is oxygenated, but the lower limb is not getting that blood. It is getting mixed blood. So the PDA is supplying the descending aortic part. So this is a diagram where it's representative. So look at that, the PDA, because of the coarctation. So this is a critical coarctation. What is happening? The antegrade flow from the aorta, ascending aorta, is not reaching the descending aorta. Instead of that, the PDA is contributing the blood to the descending aorta, and that is why the lower limbs are desaturated. In cases where there is interruption of arch, so interruption of arch is place where there is the arch stops at some point in time. So this is the post left subclavian artery. There is no aortic arch that is developed, and the descending aorta is completely formed by the PDA. Third case scenario is now it's the opposite. So what if the right upper limb has low saturations and the right lower limb has higher saturations? So now something is happening at the heart level, because there is something wrong at the level of the heart. That is why the right upper limb is low saturation. So maybe there is something like what we already saw, the transposition of great arteries. So this is basically happens when you have a duct dependent pulmonary circulation. So this is a hypoplastic left heart. So in this, what is happening? The left side of the heart is hypoplastic. So the mitral valve is small, the left ventricle is small, the ascending aorta is small, or these may actually be completely, that there might be aortic atresia as well. So it might be non-existent or only very trickle of flows are coming from the left ventricle. So what happens to the blood? So when the blood comes from the pulmonary veins to the left atrium, all of it traverses to the right atrium through the patent foramen ovale, which is now becomes like a atrial septal defect, a bigger defect. And so all the blood is now getting completely mixed in the level of the right atrium. And now this blood is now oxygenated. So you have a good saturation in this blood because most of it is coming from the left atrium. Nothing is going down the left ventricle. And that is why the upper limb saturations will be lower because of the decreased flow, and the lower limb saturations will be better. So this is another case where we saw DTGA, that is again pulmonary artery coming from the left atrium. So the ascending aorta coming from the right ventricle. So this right ventricle pumps deoxygenated blood into the ascending aorta. That gives the lower limbs, upper limb saturations are lower because of the deoxygenated blood. But the PDA is supplying the descending aorta, so the lower limb saturations are better. So this is a fourth case scenario wherein we have saturations are normal. So both upper limb and lower limb saturations are normal. But anytime the child starts crying, the saturations drop and they again improve when we give supplemental oxygen. So what is happening here? So this is not a cyanotic heart disease. It can be a lung disease, of course. When you have a lung disease with pneumonias, you might have that the patient, when it exerts, more oxygen is required. That time the saturation falls, and if we give supplemental oxygen, it increases. But another differential diagnosis is any congenital heart disease with pulmonary hypertension. So what is happening here is there is increased pulmonary blood flow, and that is why the patient has congestive cardiac failure. And in the neonatal age, most common causes the patent ductus arteriosus. So this is the patent ductus arteriosus, which communicates with the pulmonary artery in the aorta. And again, you cannot rule out the PPH. Now we'll go to the blood pressure. Second point, first point we saw is the forelimb saturation. Second point is the upper limb, lower limb blood pressure. So how can we diagnose congenital heart disease? Or these are the clues that we can pick. So again, the baby's upper limb saturation is 100/70, a little higher for a neonate, and lower limb saturation is 70/50. So there's a difference of 30 in the systolic pressures of the upper limb and lower limb. So this is a clue. What can you think about when you see a situation like this? Yes, so this is possibly a coarctation of aorta situation. Here the saturations in upper limb and lower limb are both normal, more than 95. Because the coarctation is not critical, the PDA is not involved here. just the upper limb pressures are high because of the stenosis. So coarctation of aorta is basically narrowing of the aorta, that is the main blood vessel which supplies blood to the body. So there is narrowing. So what happens is, before the narrowing, the pressures start increasing so as to supply the blood to the lower part of the post-stenotic vessel. So just to summarize, I just want you to look at the numbers to catch the clues, look at the saturations, look at the blood pressures, and these are the different scenarios wherein you can actually look at these and have some suspicion that the child may have a congenital heart disease. And echocardiogram is the most useful diagnostic tool in such cases. So you have a suspicion, please send a patient for a quick echocardiogram and we can diagnose the heart problem. So these are some other situations which can present in the OPD wherein we can suspect. So this is a 1-year-old child weighing 5 kilograms, repeated respiratory infections, father has asthma, has been treated with bronchodilators, nebulizations, but not getting better. They say he's feeding well, non-dysmorphic. So on examination, non-dysmorphic, baby's tachycardic, tachypneic, there are conducted sounds, no murmurs, and you do an X-ray and you see this X-ray. So in this X-ray, visibly, you can see that the cardiac size is bigger. So usually in children, the heart should occupy just little more than half of the chest cavity. So up to 55-60%, we say cardiothoracic ratio is normal. This looks like more than that. Now, this is a very common scenario in the OPD, and I want to highlight this because these are the differential diagnoses we can think about it when patient comes with repeated respiratory infections. So first one is VSD, recurrent bronchiolitis, a pulmonary AV malformation, airway malformation, or a primary ciliary dyskinesia. So since we are in a cardiac forum, it's but obvious that the correct diagnosis in this child was a ventricular septal defect. I will give you the reasons and I'll also tell you how we rule out the other possibilities. So in this child, what was the failure to thrive suggesting? That it is a large left to right shunt. Lot of the baby's energies are being utilized by the cardiac activity to keep pumping for the. So what is happening is the left ventricle has to pump blood to the body, but it is wasted every single cardiac cycle. Lot of blood is wasted to the right ventricle. So the heart rate increases to give the same amount of cardiac output. The respiratory rate increases because it is receiving more blood. So lungs are wet. So all this takes up the energy of the child. There is very less calories fed for growth, and that's why there is failure to thrive. Why repeated respiratory infections? When there's pulmonary overcirculation, blood is a good nutritive medium. So bacteria, viruses grow very fast, and the child is more prone for respiratory infection due to airborne diseases. Why no murmur? So not all heart diseases can have murmurs is what I want to actually highlight, and this is one of the take-home messages that I want to give. Because if the pressure equalization happens very quickly, so what is happening here is the left ventricle, which is a high pressure ventricle, is connected to the right ventricle, which is a lower pressure ventricle. But if the hole is large enough, the equalization occurs very soon, immediately as the heart goes into systole. So the cardiac cycle is divided into systole and diastole. So in VSDs, usually you should get a pan-systolic murmur is what we read in textbooks. But in large VSD, you may not get a murmur, or you might get a very faint murmur, but because of the conducted sounds, you can easily misdiagnose it, or you may not be able to hear it. Again, bilateral conducted sounds may be because of the pulmonary congestion. So here, big heart is the clue. Why not recurrent bronchiolitis? Because we did not have any viral triggers. There was no improvement with bronchodilators. The X-rays, there could show hyperinflation, but our X-ray did not have hyperinflation, and we had cardiomegaly, which is not seen in bronchiolitis. Why not a pulmonary AV malformation? Again, these are actually localized lesions, so you can see opacities on the X-rays, and cardiomegaly or diffuse plethoric lung fields are not explainable by that diagnosis. The third one is what primary ciliary dyskinesias. It is usually associated with situs inversus. You have chronic sinusitis, wet cough, and these are all absent here. And also plethoric lung fields as well as cardiomegaly are not the features. So big heart is the big clue. Kindly in all your X-rays, look at the cardiothoracic ratio. If you see that there's a heart shadows occupying more than half of the chest wall, then you should refer the child for an echocardiogram. This is second scenario. A 7-year-old girl weighing 28 kilograms has easy fatigability since the last 6 months. Her appetite has decreased and the weight gain is poor, and some vague chest pain she's complaining. Very common scenario which we see Again, the child is non-dystrophic. On auscultation, the lung fields are clear. There's mild hepatomegaly. No other murmurs are seen. Again, we do a chest X-ray. We see that the lung fields are looking fine. Maybe the heart shadow is a little bigger, so there's mild cardiomegaly. So this patient was actually sent to me by my friend who's an adult cardiologist. He did an ECG in this child because of the vague chest pain, and he saw that there is some kind of left ventricular strain pattern, some kind of left ventricular hypertrophy. So that we diagnose in the ECG when we see these changes of STT changes in the lateral limb leads. So now this one, he had done an echo. He said, this looks to me like a left ventricular hypokinesia. That is dysfunction of the left ventricle, so like a dilated cardiomyopathy. And he said, I'm referring this child to you. Now, when the child comes to me, the differentials which I was thinking of after this call was that maybe it is dilated cardiomyopathy, maybe it is viral myocarditis. So it's like a temporary thing when the virus affects the heart and there is dysfunction of the left ventricle. Or it can be an anomalous left coronary artery from the pulmonary artery. So in this condition, what happens is the coronary arteries have to arise from the aorta. But what if it arises from the pulmonary artery? So if the left coronary artery arises from pulmonary artery, the left heart is not going to get high pressure blood from the aorta. It gets blood from the pulmonary artery, which is deoxygenated, and the heart perfusion, the muscle perfusion hampers, and that's why the ventricle starts getting dilated and dysfunction. And why in coarctation of aorta we get dilated cardiomyopathy is because if the stenosis is very tight, there's a lot of afterload on the heart, and that's why the cardiac muscles then start getting dilated and then start failing. So in this child, there was no history of any fever or any recent infection. So we thought, okay, viral myocarditis. Of course, we have to confirm it with blood investigations. And this was the echo when the child came to us. So if you see, this is the left ventricle. So the whole right ventricle is very small. The left ventricle is quite enlarged and there's hardly any contracted. There's no squeeze in the left ventricle. And then we saw that it was indeed Al Kappa. So the pulmonary artery was giving rise to the left coronary artery. This image, yeah. So if you can see, then this is the pulmonary artery which is giving rise to the left coronary artery. This is how it looks on the CT. So we did a CT scan. We saw that the pulmonary artery, it's all labeled here, is giving rise to the left coronary artery. And that is why so we found a cause for this dysfunction. It's very important in a child with dilated cardiomyopathy to find out reversible causes. Sometimes it might be just vitamin D deficiency. Sometimes it might be just thyroid disorders, like thyroid function defects. And these Al Kappa, coarctation of aorta, these are all reversible causes. And if they're diagnosed timely, then recovery, look at the recovery. So this child, beside Dr. Pradeep, he did a beautiful surgery. He did the coronary reimplantation to the aorta. And this was the post-operative echo right in the first post-operative day. So our ejection fractions have improved from those 15-20% to 50% on the day one. And I'm sure they will now get back to normal as we see the follow-up. So outcome is symptom-free, and now she's gradually gaining weight. So again, to say that Al Kappa, coarctation are some of the commonly missed cardiac causes of cardiac failure, which are fixable. And so echocardiogram is not just a test in these kind of children, but it is a life-saving test for these children and should always go ahead and get an echocardiogram done in any case of suspicion. This is another very common scenario you get when we have adolescent girls which come to the emergencies with a seizure-like episodes, 2 to 3 times, they are like having syncopes. Patients, the child suddenly becomes pale, collapses, and followed by 10 to 15 seconds of unresponsiveness. So this girl in one instance also had a little jerky movement. So they thought maybe she's suffering from seizure disorder. But she could spontaneously gain consciousness and feel exhausted afterwards. So 1 or 2 days she would just lie down and not go to school. And these episodes often used to occur with her when she was running or swimming or during emotional stress. So one time when she was going for exams and they were distributing papers in the class, she started getting fainting episodes. So now we did a little more digging up in the history, but there was no history of family history of such a disorder. Although her maternal uncle died at the age of 25. So we always ask about sudden cardiac deaths. So any kind of death due to swimming accidents, car accidents, burns, All these we can actually attribute to sudden things like seizures or arrhythmias, because in that situation, if you're in a situation where you cannot, if you have the arrhythmia or a seizure, then you might actually be prone to an accident. So we had a history of maternal uncle who had died due to a car accident. So when we saw the girl, her heart rate, BP, respiratory rate was normal. We did not find anything in the examination. Her bloods were normal. So we did the glucose, electrolytes, CBC. Then we did the ECG and the EEG, of course, because we wanted to rule out seizures. So this was the ECG, and the EEG which we did came out to be normal. So here the ECG differentials we kept were epilepsy, vasovagal syncope, WPW syndrome, and long QT syndrome. So I'm not able to see what you're thinking, but yeah, the answer in this case was a long QT syndrome. So if you could see the ECGs, you have a long QT interval which is 537 milliseconds. So normally up to 460 is normal, and if you see at the T waves, so there is T wave alterance. So ECG is again, so trust the rhythm to solve the mystery. So many times in such a situation, we think that it is a seizure, but it might be actually a cardiac rhythm problem. So we'll just go through why the other DDs were ruled out. In epilepsy, you will get, of course, you'll get brief jerky movements. But in this case, why the brief jerky movements were occurring is because of the decreased oxygenation in the brain. So there is a phase when the brain oxygen levels go low, then you might get seizure-like episodes. You might get involuntary movements of your limbs. Why not vasovagal syncope? Because in vasovagal syncope, typically there will be a prodrome, there will be a pain or nausea or something which will stimulate that syncope, and it is not triggered by exercise or emotional stress. Long QT, we saw that this patient had long QT syndrome, and WPW again, when it presents, it's actually sudden onset palpitation. So it is like a switch on, switch off phenomenon. And the ECG here is different. So you have a short PR interval, you have delta waves, which are absent in this one. So in this cases, next step, what we do is we let the family go for genetic testing, family screening to see any other members have long QT. We ask the patients to avoid QT prolonging medications. This list is readily available online, which you can refer to anytime. And if this incidences occur very often, then we go for an implantable defibrillator. So again, just to we are coming to the end of the session, I would like to say that cyanosis, poor feeding, failure to thrive, exercise intolerance, easy fatigability, chest pain, palpitation, unexplained syncope, or family history of sudden deaths, all of these children should be on your high index of suspicion. If a collapse neonate comes into the ER, of course, shock, sepsis, metabolic problems are common, but always think of drug-dependent lesions. Always do upper limb, lower limb saturations and blood pressure, get an echo done. If there is a long-standing fever, of course, it should be connective tissue disorder, but always think about infective endocarditis. Look for murmurs, do a X-ray chest, look for cutaneous markers, ECG and echo. Recurrent respiratory infections, most commonly due to asthma, allergy, TB, all of it. But also think about acyanotic heart diseases. Especially if the tachypnea is out of proportion to fever, patient is not having fever, still is tachypnic. If there is quiet tachypnea, that is subcostal, suprasternal alanasa retractions, but just the diaphragm, subdiaphragmatic area moving, that is called quiet tachypnea. Look for it and send the patient for an echo. Vague abdominal pain, of course, can be a stomach bug, can be food intolerance, mesenteric lymphadenitis, but always look for and think about heart failure, dilated cardiomyopathy, pericarditis. So these are all, you can look for signs of fluid retention. You can do an ECG and echo, which can give you the diagnosis. Failure to thrive again can be because of malnutrition or short stature, but always think about shunt lesions with increased pulmonary blood flow. So in a child who's eating well, so this will be a typical history that he's eating well but not growing. Then that should be possibly a congenital heart disease. Leg pain can be growing pains, very common symptom in the OPD, but always palpate the femorals and suspect coarctation of aorta. Do the upper limb, lower limb blood pressure. So be vigilant is what all I wanted to urge today, and you play a critical role in ensuring that children receive the specialized care that they need when they need it most. So only in few places suspicion, being more suspicious is better, and this is one of them. And that's my take home message for all of you. And this is our cardiac team. We have cardiologists, cardiac surgeons, perfusionists, anesthetists, intensivists, our cath lab technicians, our echo technicians, all of us together. We need each and every one for the journey of the child from the time of diagnosis till we send them home. Thank you from the team. Now we can take any questions if now. Or we can, you can also put them on the chat and we can discuss about them at the end of the session. Now I'd like to welcome Dr. Manasi Kolhe. She is a pediatric intensivist who manages all our post-operative patients in the ICU. And over to you, Manasi.
Good afternoon, everyone. Thank you, Dr. Priya, for the wonderful lecture. So today, I would like to discuss few problems which we encounter in our OPDs on a day-to-day life. Probably few of the patients which we face are probably sometimes they are diagnosed, sometimes they are not diagnosed. Sometimes they are in a pre-operative time period. Sometimes they are planned for operations within few weeks, and few of them are post-operative. And already, if the parent knows that yes, the patient has been diagnosed with a cardiac disease, then they come up with lot many questions about the recovery, about the long-term outcomes for the patient, which Dr. Sen also spoke about. But there are small things which we need to take care as a pediatrician, as a first person who can answer their questions. And there are a few things which as a parent they can call and they can ask you, which need not go to the cardiologist or a cardiac surgeon, and we can take care of them. I'm going to speak about few of those questions. So these are the topics I'm going to discuss about. Timely diagnosis, Dr. Priya has already spoke about this, that how we can go for the early diagnosis. Earlier the diagnosis, better the plans we can formulate for the patient, and better the counseling we can do to the parents, so that they can decide what they want, how they want, and they will be mentally, financially, socially will be prepared. But to the addition of that, I would always say that whenever a patient comes at whatever age, especially when they come for their primary vaccinations at 1.5 months, 2.5 months, and 3.5 months, please take a time to get your stethoscope out, listen to their hearts, touch their bellies, and also look for the pulses, because if something like coarctation or if a VSD, which is now has started troubling the patient, we should be able to pick it up at those visits. And moving on to the growth and the nutrition, which Dr. Priya said, the usual complaint is my child is eating, but he's not gaining enough weight or he's not growing as expected or as a normal child. So that is one of the uh, feature which can lead us to the diagnosis as well in cases of congenital heart defects. But let's understand first what is filtering growth, or how do we monitor it. So basically, the growth filtering is defined as falling more than 2 centiles downwards in a time period of 1 month. That means if you have measured a weight, if suppose at the first visit it was sitting at 97th centile, and if it is falling to suppose 50 centile or 75th centile even, then that means something is definitely wrong, something needs to be done in those cases. Just an interesting fact, in cases of cyanotic heart diseases, this growth restriction is similar. That means they don't grow in their weights as well as they don't grow in their lengths or heights. While in acyanotic, those are mostly asymmetrical. They usually gain their heights or lengths, but they fail to gain the weight as expected. And this is a chart which is not exactly from for the OPD person, but I just wanted to emphasize this is a chart for somebody who's working in ICU, and see how frequently they are uh, asking or they are expecting us to monitor the child when he is, especially he or she is in the ICU. And similarly, it should be plotted, it should be monitored in our OPDs as well. What we usually say whenever the patient comes for the first follow-up of after the surgery, then after the which is the first follow-up, which is almost around 3 4 weeks after the discharge, then you should monitor the growth for at least every monthly over the next 6 months, and after that you can see where he is going, and accordingly you can reduce the frequency of plotting, monitoring the growth on the growth charts. And there are different causes why this patient fail to gain adequate weight or height. Let's discuss those, because if we understand what is the pathophysiology behind it, then in that case we will be able to aim what we need to do in such cases. The first one is fatigue on feeding. Obviously, as a pediatrician, what we can do is we can give them easier ways for um, having their meal. Like if it is an infant, then probably NG feeding, or rather than actually asking them to suck for a long time, something like vati chamcha feeding, which requires lesser energy, then that would be helpful for gaining some weight, and so that we can give a better weight baby for going for the surgery. Then many of the patients, especially those who are having increased blood flow to the lungs, we try to restrict their total fluids, and that is another challenge. So in that case, we would like to use milk fortifiers or something like MCT oils to increase the total calorie intake along with the normal formulas. Some few of them have poor absorption due to congestive cardiac failure. Few of them have increased metabolic expenditure. Obviously, most of the energy is spent in the metabolic expenditure, and very less percentage of the calories which they actually consume is taken up by the growth factors, which will give you to the increased height and weight. Early satiety, frequent infection, which are like bumpers for growing in a linear fashion, and also frequent use of antibiotics affecting the gut flora. These are few of the risk factors which will hamper the growth. So there are few things which we need to consider. So before we can introduce or reintroduce the feeds after the surgery, there are few cardiac conditions which need very cautious feeding, especially something like obstructive lesions. If there is a tight coarctation of aorta, or if there is a hypoplastic arch, or many of the clinicians who start on prostaglandin, they prefer not to feed the patients. It is not an absolute contraindication to start the feeds, but yes, at the back of our mind, we should keep it that there are high chances of turning into the necrotizing enterocolitis, which we can diagnose with the clinical findings as well as few of the investigations. And from there, we can go ahead for the management, whether we need to stop the fluids or we need to go. All right. Then another question is choice of feed. Whenever a parent comes that this baby is not able to take my feed, what should I do? So there are multiple options which you should think of. If the patient, if the baby is not able to suck the feed, or uh, he is there a, and many of the mothers say that I don't have adequate amount of feeds, so definitely EBM or express breast milk will be the option for them. There are, as we have already discussed, there are many milk fortifiers which definitely increase the caloric uh, value of the feeds, but definitely they don't give enough proteins, which we will be discussing later. And also, if a patient is very sick and we are not ready to we are not able to introduce the normal either the formula feeds or the EBM, then there are ready to use protein hydrolyzed feeds which are readily available in the market. Those are also good options to keep the parenteral nutrition on. And there is always a debate when to start the NG feeds, especially in the cases where we need some weight gain in patients. I would say, or there are recommendations that if we have seen the definition of the faltering growth, like dropping the 2 centiles within a 1 month, then definitely if there is no problem with the type of the feed, then definitely we have to go for the NG feed. There are few countries which prefer NJ feed rather than NG feeds, but I have seen this more in a Western world because it is continuous kind of feed, and then you have to uh, provide with the professional who can take care of the NJ feeds. And few of the patients who have or who will be facing the other not the oral route for a longer time, like the CP patients or somebody who has got uh, like vocal cord palsies, which will need either long time route for other route for the feeding. The gastrostomy tube is also frequently used route of the feeding in many of the heart defect patients. And of course, if the patient is very, very sick, nothing is going enterally, then total parenteral nutrition is one of the option which is available. But obviously, we need to have the central venous line and the patient needs to be admitted for the same. So basically, parenteral will be always the first choice of feeding. And just to emphasize that it's not just the calories, we need to see that they are eating the perfect portions. There have been many studies that if you give only 2.5 to 3 grams, which is almost double the value of the proteins which are required in patients with the heart defects, to actually see the growth or to see the catch-up growths. This is because most of the patients who to whom our Indian mothers love to feed the babies, but they try to feed the babies with higher amount of the fat. So it's our responsibility to emphasize them, to give them the options which are high protein feeds according to their food choices. That these are the proteins, and these should be at least 30 to 40% of the plate, which should be which the baby is having. It those should be made of proteins. And there are multiple micronutrients which should be provided, but folate and vitamin D are the two micronutrients which have been proven which need to be supplemented. Otherwise, the growth of the child will be definitely hampered. And there are few special circumstances where you need to choose special type of feeds, like somebody who has got CCF and the back pressure changes causes the protein losing enteropathy. In those cases, the liver is also increased in size and not functioning very well. At that point, you need to give high protein with fat soluble supplements. And another one is chylothorax, which will need high MCT diet along with adequate proteins and electrolytes. For certain time period, at least, we usually recommend around 3 to 4 weeks, and after that, reintroduction to the low LCT diet is usually recommended. Apart from this, somebody who has undergone Norwood surgery and is in an interstage phase, they also need specific diet requirements, which are very balanced. They need to be assessed almost every 15 days or so. Moving on to my next topic, that is the development in the child. It has been seen that almost 50% of the babies with heart defects have developmental delay at some point of age. They may vary in severity, they may vary in the domain which has been hampered. The motor skills are and that too gross motor, those are the most common hampered skills in these patients. And these are the high risk factors which might give rise to the developmental delay. It could be genetic. If a neonate who had suffered from very low saturations for significant amount of time uh, during the surgery or during the perioperative period, there are so many things which might reduce or hamper the adequate blood supply or the sugar supply to the brain, which might give rise to the further developmental delay. Strokes might happen. There are few social and family, like uh, if they are very poor, not able to provide adequate nutrition, then also they can lead to the developmental delay. But what can we do to prevent these developmental delays? So early diagnosis of the genetic syndromes, and if they have some curable things, like in cases of Down syndrome, they usually have hypothyroidism. If you provide them adequate amounts of thyroid hormone or thyroxine, then probably they have a better development in their life. There are some fetal and perinatal neuroprotective things which we can do. We can do prenatal detection of congenital heart disease. Also, timing of the delivery should be perfect, and also the delivery room should be equipped for facing difficult situations. Surgically, we can definitely do few changes like minimizing deleterious effects of CPB, neuroprotective measures in the ICU, but essentially early introduction of the neurodevelopmental specialist in case of any red flags. Here, I would like to take a minute and say that if we usually have got cutoff values for when we should introduce the care in cases of developmental delay, like if somebody has a cutoff of 15 months for a child to go to send him to the physiotherapist or to the developmental specialist around 15 months, then in cases of uh, children with congenital heart diseases, it should be started at slightly at a lower age, like around 12 months. If you can refer, then earlier the intervention, the better the prognosis will be for that patient. Usually, the wait and watch therapy does not really work very well with the patients with heart diseases, because of these patients who have already have gone through few of the complications. They won't take any further delays very nicely. So basically, this is a slide showing that whenever we are trying to treat a patient with developmental delay, it should be family centered, it should be comprehensive and coordinated system of care where there are neurodevelopmental specialists, physiotherapists, speech and language specialists, there are occupational specialists, geneticists, and as a master of the orchestra, you need to formulate when to send, where to send, and obviously keep on chasing the patients that they do go for their appointments is very, very essential. As there is improvement in the treatment of the patients with congenital heart disease, there are so many other psychological things which we have been facing, especially in the adolescent age group. Those are mainly anxiety, depression, and in the younger children, ADHD. In elder children, OCD. These are all at increased frequencies in cases with congenital heart defects, and probably earlier we seek for the help, better will be the prognosis for these children. Shifting to the next topic, which is infections and vaccinations, and there are so many risk factors which we already have discussed that will make them prone for the infections, especially the patients with the pulmonary congestion. They are more prone for in the viral infections like RSV, and they will land up into ICUs with mechanical ventilation. So it's very, very necessary to prevent them from having these kind of infections, as well as treating them as soon as we suspect any kind of infection with a special uh, you know uh, thinking process, that is this an infective endocarditis. Any patient may be cyanotic, but if he is having a structural heart disease and comes with a fever, you should always think that is it an infective endocarditis, and many of the times it's not, it's just a viral infection, but it's always should be in your thinking process. And what we can do as a first line medical medicine provider to avoid is that very few times I say that yes, you need to start on the broad spectrum antibiotics in such cases, but definitely before you refer them to the tertiary center, please give them some antibiotics, do some investigations, and then send them to the tertiary care. And then the tertiary care should come down on the antibiotics if it is found to be a non-bacterial, non-fungal disease and just a viral infection. And how can we prevent infective endocarditis in particular? That we emphasize on good oral hygiene at each and every visit. We should at least grossly examine their oral cavities, see that if there are any caries, if the caries are there, then please send them to the dentist. Treating the skin infection and not letting them sit on their skin for a long time. It could be bacterial, it could be fungal, and also the antibiotic prophylaxis is needed in few of the dental procedures which are more invasive rather than not just handling the enamel. And of course, our favorite vaccines. Apart from the vaccines which are been introduced by the government, um, these are the vaccines which should be reinforced, especially the pneumococcal vaccine and the annual influenza vaccine. Uh, Usually, we say that these are the optional vaccines, but this should not be the case in patients who are having congenital heart defects. And also, many of the patients come with the questions to us that when should the vaccine can be given. So usually they say if the surgery is planned, then before going for the surgery, the last vaccine should be at least 4 weeks before. And as soon as after the surgery, whenever the patient has started living the normal life, normal activity, normal food, there is no contraindication not to deliver the vaccine. And also, few of the patients who are already immunocompromised, like Down patients or any other syndromic patient, in them the booster should be reinforced because they will build inadequate response to vaccines, and boosters are definitely should be in their vaccination pages. And also because new vaccines have been introduced every year, every month, every time. So we need to go through the vaccine chart of the adolescent population, or somebody who is trying to go into the pivotal age, who has congenital heart disease, and see whether we need to do something about their vaccines or not. There is a nice catch-up vaccination which has been given by IP, Book of Immunization. Definitely, it's worth having a look into that page when a patient who is entering the adolescent age group and has not been adequately vaccinated visits your clinic. And there are few pulmonary associations, few of them we definitely know, which are associated with the congenital heart disease. But I would like to emphasize on the first one, that is the anatomical compression of the airways, which could be due to airway malacia, and which might lead to the atelectasis of the lungs. So whenever a patient is planned for the surgery, and I'm saying this because we have been facing problems quite frequently with such kinds of patients, that the patient might be symptomatic and asymptomatic. If the patient is asymptomatic, then we hardly can do anything about it. But definitely, if a patient has pre-operative symptoms of having stridor, not able to make adequate, volume of the noise during cry, if he or she is having subcostal retractions, if the patient needs to if the patient is snoring during the sleep, these are the signs which might indicate that there might be some associated airway anomaly as well. And it might it might increase the ICU stay. It might lead into extubation failure. So please do airway assessments, uh, either through the CT or through the bronchoscopy, and make sure that there is no associated airway anomaly before the patient is taken up for the surgery, because the morbidity increases if we need to uh, you know diagnose the patient after he has undergone the surgery. And obviously, the comprehensive care along with the ENT surgeons, the respiratory surgeons are needed in these cases. Obviously, post-operatively, these are mainly for the ICU people, that lung protective strategies should be implicated, and also to avoid the infection, some post-operative uh, antibiotic prophylaxis should be given. Moving on to the syndrome, so this kind of charts are not very unusual. We have seen this chart since we have started our medical training. It's impossible to remember all these charts. So, but at least whenever you see different faces, different limb structures, uh, or something uh, that is not looking very usual, it's wise to go back to the books, see if it fits into something else. If you are not able to do that, please do refer them to the geneticist or the neurodevelopmental physician or the neurologist, at least for screening. And not the least, many of the times these cardiac patients need to undergo the procedures which are not related to the heart operations, like dental procedures, or in something musculoskeletal, skeletal, for the fixing their foot or something like that. At that point, this is a chart which our cardiac anesthetists usually do follow and look into each and every system. But if the patient has been sent for a pediatrician's review, please go through all these things before you say okay for going for the surgery, so that we don't have to tackle the complications of something that has been hidden in their bodies already. And this is a checklist before the procedures. And what can we do with the patients which have been discharged, had a surgery, and have come to the OPD, your OPD, for a routine follow-up or with some sickness? At that point, I always wonder, am I dealing with something that is of cardiac origin? And things that might help are we should check the condition at the discharge summary. Usually it has been written that this was the saturation at the time of the discharge summary, this was his weight, this was his respiratory rate, was there any abnormal finding which will take time to heal, something like that. Also look if the surgery that was done was corrective or palliative. What are the ideal saturations? Like for a shunt, the saturations of 75 to 85 are okay, but somebody who had a complete correction in the case of top, he's now saturating 85 won't be okay. In that case, we need to look into what it is, and then according to that, refer him to the higher center. Also, please go through if there was any non-compliance with the drugs, if there is any over usage of the drugs, because many of our patients are teeny tiny, and there is a possibility that the whole tablet was given instead of 1/4 tablet. Please look into that. Is there any recent change, major changes in the lifestyle that might also give you some clues? And thorough clinical examination will definitely guide you towards one system, which is a primary system giving rise to all the problems in the which you can see. And most likely to be the cardiac cause after all these things is, I would say these are the red flag signs post-operatively. Is there new onset of central cyanosis, or if there is increased cyanosis, this can be guided with your SpO2 monitoring. If there is fever with signs of heart failure, probably you are dealing with infective endocarditis. Is there any facial swelling restricted to the upper body? In that case, you need to think whether he was a gland, and probably that is obstructed now. And now, new onset respiratory distress without fever, probably you are dealing with something primarily respiratory or pleural effusion or pneumothorax. Please look into that. Is there any new onset of murmur, chest pain, decreased exercise tolerance? In that case, if you think it is a cardiac and not can't be managed, then what should I do next? That is another question. So please examine the child, go for your ABC pathway, maintain airway, maintain your breathing, see if he needs a definitive airway, some fluids, electrolyte correction, correcting the hypoglycemia. If all these steps, whatever you can do at your place before transferring the child. So few of the baseline investigations so that you can have some directions where you are going, if something that needs to be done even before shifting, like if the patient has a pneumothorax, then probably you need to decompress it even before shifting to the higher center. If there is a suspicion of infection, don't think about it much. Give broad spectrum antibiotics then and there, especially if the patient is looking really, really sick. That can be de-escalated. The antibiotic course can be stopped at the later age. In cases of cardiogenic shock, if possible, then central venous catheter. Otherwise, administering inotrope through the peripheral line is in a very diluted formation is not absolute contraindication. And always we are available on the phone for expert opinion. You can always call them and ask for their expertise in what should be done next, and then transport with the system. So basically, it's a multidisciplinary care, and let's do it together so that our warriors will have a beautiful, nice life. Thank you.
Thank you, Mansi. To end, we'll have a panel discussion with all the team members who are involved in the Department of Cardiac Sciences. And we'll have a question and answer session. So if any of you have any questions, please feel free to unmute yourselves and ask. What the video share is the behind.
Video is sitting for it, then we connected as such.
I don't know if video is there. You can start. Okay.
Yeah. So, I want to, we have introduced a few members of the team, but a few members have to be introduced. So I have with me right now in the panel. On the left hand side is Dr. Lopamudra Majhi. She is our anesthetist. Next to her is Dr. Vaibhav, an anesthetist. We know Dr. Pradeep, the same team, Dr. Pradhan, and we have Dr. Naveed. And Manasi is on Lopa's left. So I just want to ask each of the members some questions to get a more clarity. To Dr. Pradeep, my first question to you would be, how do you decide when to operate a child when the child comes with a congenital heart disease?
I think it's well covered by Supratim, but just to re-emphasize, it depends on the patient's presentation, the clinical symptoms. And sometimes the diagnosis itself is an indication. Like any obstructed TAVC, transposition of ventricle, transpiration of great arteries, all these are, as soon as the indication is an L kappa, they have to be done at the time of diagnosis. But tetralogy with if tetralogy patient comes in the OPD, then we'll see how the patient is symptomatic, what is the oxygen saturation, how is the anatomy, can we wait further, or something needs to be done. So it depends, we have to customize as per the patient's diagnosis and his presentation and the age of presentation.
Does weight matter?
Weight does not matter, as we mentioned in our talk also, that we have operated on the smaller weight also. So age and weight is not the criteria.
Do you prefer to wait in a case where you can wait? Then do you?
So if somebody is, let's say, 5 kilo in 5 months, but asymptomatic, yes, I would wait. But a 5 months, 5 kilo tetralogy with symptoms, I would do either palliative or complete.
So if the child is not very symptomatic, you could still want to wait because added weight gives an advantage to the child for survival.
Yeah, we have to see other things also, like how far the patient is coming from, what is the nearby facility, whether they can reach to the primary care if something goes wrong.
Waiting is safe.
Yeah. So if waiting is safe, parents want to take that much, they understand, then it's okay to wait. Otherwise, we would subject them to surgery.
So to Dr. Sen, I would like to ask you, what also a lot of patients come to us saying that, the holes of heart now are being closed without big surgeries. So are all kinds of holes, are we able to close them by surgeries? Which kind of cardiac diseases are amenable to interventions and which need surgical closures? So can you just give us a little bit more information on that?
So device closures, as you know, Priya, are what the procedures we do in the cath lab. They are similar to angioplasties done in adults, and we take catheters into the heart, and then we have special devices which can be inserted to plug the holes. I'll just show you a short video of what we exactly do in a device closure. So this is a patient who underwent a PDA device closure, and this is the setup of our cath lab. So we have a cardiologist, a nurse, an anesthetist, and also the cath lab techs. So the first step in any cath lab procedure is we have to get the vascular access. So in this patient, we took both an artery and a venous access, and this is done in the same way that the anesthetist did in the surgical video you saw. We use the Seldinger technique. And often we also use the ultrasound gauged vascular access. So now we have put 2 guide wires in the artery and the vein. And now we are putting the sheaths over these guide wires. So this red sheath is going into the femoral artery. Okay, so once your sheaths are in, you then put in the catheters. And here we have done an angiogram. So this was a case of a PDA, and this is what the angiogram looks like. So you can see here that, I'll just go back to the previous angio. You can see here that a catheter is in the aorta and the PDA is filling and then the pulmonary artery is filling. So we then take a wire across the PDA from the pulmonary arterial side, and over that wire, we are taking this delivery sheath. So you can see that this sheath is getting tracked over a wire. We are going through the groin. And as the camera pans, you can see that on the fluoroscopy machine, we are tracking this within the heart. The next step is loading the device. So devices are made of a material known as nitinol, and they have a property of shape memory, which means that when you can cylinderize it into a small catheter, and when you push it out of the other side, it will reform into the original shape. So once we have cylindrized it, we are de-airing the system, so there's no air which goes into the body. And then we put in the device through the same long sheath, the delivery sheath. And as we push it out of the other side, we can deploy the device. So you're seeing that one disc is getting deployed, the second disc, and then the final disc. So this was a 3-disc device. We're doing an angiogram to check that it's sitting well. And the last step is we would unscrew the device and release it. So that's how cath lab intervention is done. And we can close quite a lot of holes in the heart with these interventions. When we do VSD device closures, we have to be careful that we are not damaging any of the surrounding structures, such as the aortic valve mainly. We don't want to put devices in very small children if we feel that you can impinge on the surrounding structures. Of course, PDA, as I mentioned, now you have a device which can be used even in a very small preterm only.
And so how long does a typical device closure take, and how long is the hospital stay of the child?
So the child usually has a 2-night hospital stay. So if we admit today, we would do the procedure tomorrow and discharge the day after. The procedure itself usually is 1 to 1.5 hours.
Yeah, and so when the child is going home, can the child do everything normally, or do you have?
So, I mean, it is a femoral access, so we want the child to rest for a couple of days so the access doesn't bleed. And we generally tell them to avoid school for the next 2 to 3 weeks to avoid exposure to infection, similar to a post-op child. But in the long run, there's no activity restriction.
So 2 years which are less surgery. You don't
Absolutely. Yes.
So we always, in the last few talks, everybody was emphasizing upon the team involvement and the requirement of the team. So I want to ask Dr. Lopa, what is the role of this multidisciplinary team, what we call about in a case, especially in pediatric cardiology or pediatric cardiac sciences? Everybody says that we need a good team. So how does each member contribute, and actually what is happens in the team discussions? Can you just give a little bit more information?
Yeah, thanks, Priya, for this question. Actually, whenever any cardiac patients comes, congenital cardiac heart patients, they have like very complex anatomical, physiological, and developmental problems. So whenever any patient comes and cardiologist first diagnose the patient with that this patient is having this complex problem, and they take the proper history and all those things. So then we discuss those patients in our CAPMIT which consists of cardiologist, cardiac surgeon, and cardiac anesthesiologist plus intensivist. So there we discuss about the patient. So we decide what we are going to do, like whether surgically we are going to do that case, or like we are doing intense interventions or something. So once it is decided whether patient is needing further imaging like CT angio, pulmonary angio, or we need some cardiac cath for that patient, we decide in that thing. Like once it is done, then patient has been taken for surgery and surgery is done. Particularly if I'll give one scenario, like patient is tough with MAPCAS, but we feel that MAPCAS will be fine. MAPCA is major out of pulmonary collateral. So, but in our mind, we know that patient, post-op patient can give trouble, can trouble us. So if needed later on, we know that thing and will take the patient for cath, and if required, SOS MAPCA calling, we will do that thing. So whenever any patient comes, we discuss in our cath meet. Everyone is on same page, including the perfusionist, intensivist, everyone. So once that is done, so it gives us the proper outcome and how we are taking the patient. So post-op period will be maximum time. It is well managed. So, and if still we find a patient is having any other problems, like as Dr. Manasi says, it is associated with many times airway problems, sometimes hematological problems. Before taking for surgery, we try to optimize those things. So that helps us in the post-op period, like requiring a physiotherapist, requiring pre-op antibiotics, or requiring SOS NIV requirement is there. So ventilation need longer ventilation. So counseling also it is done in that way. So multidisciplinary approach in that way, it helps us to manage the patient properly. And
Every plan is made tailor-made for
tailor-made, so that
it's
the
not
in peri-operative period, post-operative period, it goes smoothly.
And as we saw that there's so many syndromes associated, so we need a lot of inputs from maybe other teams as well, the neurology, the hematology, infectious disease specialists. So truly,
Without it's not a single person's job, it's a team job. That's why cardiac sciences needs interdisciplinary team approach.
And
it is very
these
much
meetings
needed.
really help everybody to come on the same page, so everybody knows about the patient and they can pitch in their way when they are dealing with the patient. Perfect. That sounds so good. So I've seen that every child needs tailor-made plan. So same thing about anesthesia. What do you think that when you come to anesthesia part, does every child need different type of anesthesia, or is it different for children with cardiac problems? So Dr. Vaibhav, how do you go about when you're doing these CTs, MRIs? Do you deal with these children differently as compared to the other non-cardiac children?
So, as you see, as you said, it is CT, MRI, and cath lab procedures. So in cath lab, there are, as you have, sir has explained, the intervention which are treatable things. We also have diagnostic care. So all these three, CT, MRI, and cath, CT, MRI, and diagnostic care are mainly diagnostic modalities which are going to help us in formulating the plan of the patient. So here, what the patient already has a disease, in which we are, say, we are doing a CT of the patient. So we are looking for a coronary anatomy or a pulmonary artery anatomy, or say any aberrant channels which are there. So the thing is, it is diagnosing, not treating. The parents there has to be counseled very properly. The level of anesthesia, mostly what we use is sedation. We have all the comorbidities. Sometimes we have less optimized child there. Say it might be fasting more, it might be anemic, it might have some upper respiratory tract infection. So that the child needs to be taken care of very well there. Pre-op optimization, pre-procedure optimization, and the parents counseling is very important in that. Apart in non-cardiac setup, these things are there, but they are of lesser so extent, I would say. These kids are sicker, needs urgent attention, and if the plan needs to be formed, it is done on semi-urgent basis also. Say somebody comes with infracardiac TAPVC, total anomalous pulmonary condition. So he has severe PA pressure. He cannot tolerate hypoxia. He cannot tolerate any acidosis. His NPO is 4 hours. He has severe pH. With that, if you give him sedation, he will drop his heart respiratory rate and also require oxygen supplementation. So, and temperature in the consoles is also less. So these kids ranging from say 2 days to say 20 years have different problems and need to be tackled differently in say CT and CT scan basically. In MRIs, recently we started doing these MRIs for various indications. So for this also, the pre-op child communication is very important because these kids require some breath holding or expiratory holding. So these needs to be counseled properly, and we need a lot of patience with for kids with cardiac MRIs for various reasons, maybe cardiomyopathy, volume estimations, or say dynamic MRI, 3D is coming up. So all these things for MRI. For cath labs, the sir has told the closure of the hole, but what scares us the most is creating the shunt. So PDA stents and RVOD stents are the couple of procedures which are the palliative procedure in top, which is mainly done in younger age, say neonate to infants. The closing holes is also a risky procedure, but this creating a shunt or keeping them patent actually is a very high risk procedure. Most of these cath lab procedures are done under sedation, but these procedures require uh, ventilation, invasive lines, all the emergency drugs, inotropes, and post-op ventilation. So these kits require a meticulous management in cath lab also. Apart from that, these scenarios, MRI, cath lab, and CT console are away from the OT. So you have different kind of management, less trained for people there to help you out. So emergency situation is tackled differently there. So we have to be prepared as you are prepared in OT for with all emergency drugs and inotropes and everything loaded pre-operatively, and then go accordingly.
So seems very intensive, especially because you're dealing with these very sensitive hearts. And sometimes when these patients are fasting as well, they might have problems due to the fasting, due to the low oxygen. So basically giving anesthesia to cardiac patients with these kind of sensitive hearts is a big challenge in itself. So it is as challenging as actually doing the procedure, maintaining the temperatures in those rural areas. So and glucose. So child might have hypoglycemia, hypothermia, and that can cause severe brain damage instead of the procedure causing problems.
And
These
most
things are
importantly,
happening,
we are not treating the disease. Here, if the patient with the sick kid with the parents who has come with the kid goes into the diagnosis and suffer some complications, the way of counseling is very important.
Sure. So I can understand the high intensity job that you're doing, but also about I want you to tell me more about what the patients are going through. So I know that all these procedures must also be involving a lot of pain. So what kind of pain management issues are you deal with, and how do you tackle them?
So as Dr. Lopa has told already, it is a multidisciplinary thing. The kid is counseled and parents are counseled prior also. So the kid, we take pre-operative, for the care of the patient starts from pre-operative area only. The anxiety of the patient has to be calmed down. They are pre-medicated. And analgesia forms an integral part of anesthesia along with the sedation. So there are multiple analgesic modality which are used intra-op and post-op. Intra-op, we have opioids, which are mainly fentanyl, morphine. Downstairs, sometimes we use, I don't know, Fortwin sometimes. And post-operatively also we use short-acting opioids like fentanyl in different forms.
So
We have
how
fentanyl
does the
types.
pain management go about in these patients? So do they have pain, little bit pain or no pain, or like is there any day when all the patients suffer a lot of pain and then over the time the pain goes down? So what is the pain that they experience usually during the procedure or after the procedure?
So see, as sir showed you the video and we saw the cath video also, there are various stimulations which are going throughout the surgery along with the hemodynamic instability. So in that, opioids are quite helpful with hemodynamic stability. Along with it, sometimes we use our regional anesthesia technique, what we call blocks and caudal epidurals, where we use mainly there are 3-4 blocks like which we have recently started using, say erector spinae block, paravertebral block, and
So
caudal.
all
Which
these
you,
help
so
to
these help in mainly in
procedure.
intraoperative period and sometimes post-operative period. With complexity of the procedures increasing and we are going younger and younger in age group, these cases or these techniques are helpful for our early recovery thing. So patients are recovery is earlier because they are relatively painful.
Pain.
So the pain is there for say 1 or 2 days post-op till they are extubated, and then if the patient is having brain, mainly the pain can be controlled with your routine NSAIDs and paracetamol.
So, lot of emphasis I see is given on pain management as it is an integral part of early recovery. So, children who are pain-free will recover earlier, and so
Yeah, they
the
will cooperate
focus
with
is
you better.
sure. So, the focus is always there to keep the patient pain-free, and all throughout from the time of the admission till the discharge, we have a high suspicion system, and where we always look for if the patient has pain, and we always go
So
about
the
it.
sisters and all monitor on their daily chart the pain and also.
So how long does this actually, the follow-up take place for any cardiac patient? Do they have to keep following up with you lifelong, and do you have a cutoff date for follow-up, and how often do you call these patients or the person?
So the corrective surgeries like ASD, VSD and TOF in which pulmonary valves spared, we do the follow-up, the interval keeps on increasing 3 months, 6 months yearly. And then after 2 or 5 years, we do not call it. But every 5 years till the heart is grown up, like the heart reaches adult size, which is 15 years, the follow-up is recommended. On the other hand, the single ventricles or the surgeries which might require interventions like arterial switch or AV canals, we do recommend yearly follow-ups.
Okay, so certain conditions may require annual follow-ups, while certain conditions the follow-ups may stop.
Yeah.
Um,
In the cataract procedures, usually the first year we will follow them up thrice. After 1 month, then after 5-6 months, and then once a year. So that yearly follow-up goes on for about 5 years. And after 5 years, we usually discharge them from study.
So overall, what can you say about the quality of life or long-term outcomes of your patients?
So,
Cardiac surgery.
so more than 80% or 85% of the cardiac ailments, what we see, and what we can offer them is corrective one-time surgery. There are few patients who require staged palliation followed by corrective surgery. And there are certain surgeries in which we do the surgery, but they require change of the conduits or repair of the valves. Those are also corrective surgery, but they might require intervention for sure as the heart grows and they outgrow their size of the conduit of the valve. So those are the recommendations, but otherwise majority of the kids do not require biventricular repair, in which they will not require any long-term medication or restriction of diet or physical activity. So that they can have all sports, school going, swimming, cycling, yeah.
So it's really nice to know that, children bounce back so fast after the cardiac surgery. They live nearly a normal life. And yes, also coming back to the complications. So we saw that you said there might be some complications in the post-op period. So what are those complications, and how can they affect the child in the long term? I'd like to ask Dr. Naveed, who is an anesthesiologist.
Generally we see complications in the first 24 to 72 hours after surgery, and many of these can be life-threatening. If I had to discuss about this system-wise, I'll start with the cardiovascular system. We usually see a lot of low cardiac outputs, arrhythmias ranging from just a few beats to the tachyarrhythmia, junction ectopic tachycardias, and to the other end of the spectrum coming to complete heart blocks. We also see so a lot of our patients have pulmonary artery hypertension pre-operatively, which sometimes significantly persists into the post-operative period. So post-operative people can have pulmonary artery hypertension, for example. With the respiratory system, other than the usual complications like lung collapses or just some pleural some congested lungs, we also see complications like pleural effusions, pneumothoraxis, parathoraxis. Of course, all of these complications increase the more the child stays on mechanical ventilation, the morbidity increases. We also see diaphragmatic palsy post-surgery. We see subclotting stenosis if the child has been intubated for a very long time. When we have some metabolic derangements like acute kidney injury, liver failure, and hyperglycemia, hypoglycemia, that is also generally due to low cardiac output syndromes. You also get hypothermia, hypothermia, temperature disturbances in the post-operative period. Neurological problems which are rare, but then sometimes we do have hemorrhages and strokes, and manifest as seizures in the post-operative period, delayed awakening if the child has been ventilated for a very long time. And other than this, there are some specific complications which are seen after some specific procedures. Like, for example, if a ventilation has been done, then we can see have a overflow of the shunt or the underflow of the shunt, or if again a Fontaine surgery has been, and then you can see upper and lower body swelling. So a lot of them persist to pertain to specific surgeries that have been done. And of course, because we do this on a daily basis, we always anticipate as to what complications can be seen afterwards.
Sure. So that's a very crucial time, the post-operative period, where, as you said, anticipation is the key to prevent long-term complications. So if you have anticipated that this child may have neurological insult because of low oxygenation or whatever, so you treat it at the right time and you will prevent the child from having a long-term brain problem and developmental delay. So every small step that you take is going to actually change his life in the long term. That's a very great thing to know and the great job that you're doing. I think we have come to the end of the session.
So I can ask you a question, Priya. So can you just walk us through the operation aspect of the unit as to like when the child shows up, right from when he shows up to the hospital to the discharge?
Sure. So basically, in SRCC Children's Hospital, we not only see children in the hospital, but we also see a lot of children in peripheral camps. So we have a portable echocardiographic machine which we take to very remote areas of the country, right from we've covered states like Assam, Orissa, Madhya Pradesh, Goa, lot of interiors of Maharashtra, and we go to the not only district levels but taluka levels wherein we see children. Perform echocardiograms on nearly 150 children in a day. We screen these children, these already screened children. So most of them are children with congenital heart disease. We triage them. So which child needs to come to the hospital at what time, which can be followed up. All these plans are made. Also the detailed surgical plans, if possible, are made at that point in time. Then these patients come to the center in batches. So when we get these patients in batches of 20, 30, and this whole team is already, we know that these patients are coming, so we are all prepared and geared up. We do the echoes on the first day. So basically, a typical pathway is that investigations like echocardiogram, X-ray, ECG are the first stage investigations. Then most of the diagnoses are done at this stage. So we have a team meeting, we decide the plan for these children. Some children, of course, need advanced imaging as we have discussed earlier. So those children are taken care of. So a lot of times, as Dr. Vaibhav said, that even imaging anesthesia is a very difficult task. So we admit these patients only for investigations many a times. Some elder or low risk children can have investigations on OPD basis. So after all this, the plans are made. Patients who require interventions go for interventions, who go for require surgical approaches go for that. They spend around 1 to 2 days in the ICU in case of surgery, and in case of interventions, many times they can be discharged the very next day. So in usually within 7 to 12 days, most of our children get discharged. Follow-ups we already have discussed. So this is the typical unit running. And the focus here is basically a multidisciplinary team taking care of the child right from the time they enter, and we do not leave their hands even after they have left us. So we actually keep following them up. We see for what complications are coming up, and we again anticipate those things, and we try to treat them, not only their heart, but their whole body. Thank you so much, Priya.
Do we have any other questions from the audience? Okay.
Yeah. So I would like to thank all of you for your patient hearing and giving us this opportunity to share our work and something that we know about cardiac sciences with all of you. Hope this was there were some take-home messages and you can use the whatever we spoke about in your daily practice. And we would love to hear from you. We are always open. Our phone numbers, our contact numbers will be available to you. If you have any queries, please feel free to contact us, any of us, and we are more than happy to help you with whatever we can.
Thank you.
Thank you so much. So we'll log off now. If you have further questions, please feel free to put it in the comments on YouTube, or you can email us on the contact ID. Thank you.